Thank you, ma'am. Thank you for that. Good morning, everyone. I'm glad there are a lot of residents.
Timer on
That's
करेंगे
my
please.
target audience for today. So my talk is on how not to miss superficial foreign bodies. So it's one of the most common cases we encounter in ophthalmic emergencies in the casualty, and I'm sure the first and second year residents go, that's the first thing. And when you remove your first foreign body, I know how exciting that is, especially if it's a corneal foreign body, 26G se nikala. So when most of them are easily spotted, but few are easy to miss, either because it was a busy OPD or it was a very busy mind in a not so busy OPD. All that we need to do is look for it with our eyes and our mind, because the eye can see only what the mind knows. So this first case, 40-year-old male presented with injury with a sugarcane leaf 3 days back, pricking pain, eye pain, and was on antibiotic drops elsewhere. He was told that there is some infection on the cornea, it will resolve, and was diagnosed as corneal abrasion and infiltrate. Yes, it does look like infiltrate. We know the description, some whitish thing on the cornea, but here I would like to emphasize on the importance of indirect illumination of your slit lamp technique. I say you do one gross broad illumination, you are definitely going to miss this. So in the second picture, when you do an indirect illumination, you are seeing a shadow of something in there, and after you stain, you can see that the half thing that's protruding outside is taken up the stain, or it's highlighted, where the other is not. So these are basically the thorns, the sugarcane leaf ke thorns sitting in a row. So why was this missed? Because of misinterpretation. You look at the foreign body, but you think it is something else. Now, because of indirect illumination, you are also able to see that there are two thorns sitting exactly parallel to each other. Now, why it is important is, if you miss that and you remove the thorns, once you remove one, you're going to cause some amount of stromal disturbance. After that, the second one will not be visible. So before you attempt, you need to see how many there are exactly. Removing it is very simple. It usually goes in a diagonal or way. So just the direction in which it has gone in, you just have to tease it out in the same direction. Sometimes using a forceps, a fine forceps, is also a good idea, that cause much lesser stromal disturbance than a needle. A finer forceps is preferable. Now the second case, a 30-year-old male, again injury with sugarcane leaf. So when this was brought to me by a junior consultant saying, ma'am, kuch nahi hai, there's a small infiltrate and a little subconjunctival hemorrhage. I said, okay, theek hai. It looks there's a small infiltrate, there is a subconjunctival hemorrhage, but as a routine, any cornea case, anything on the cornea, even if you're sure there is nothing, please take a moment and stain the cornea, stain the eye. And to my surprise, there was a large stain positive conjunctival epithelial defect. Like, why should there be a conjunctival defect? And then I had a closer look. So this is a direct illumination. You're directly focusing on that, nothing is seen. But when you do an indirect illumination, you're able to see some linear black thing in the subconjunctival space. It's more obvious here. So there was this foreign body sitting in the subconjunctival space. Now why did we miss this? Because of misdiagnosis, attributing the symptoms to some other sign that's either a coincidental or an associated sign. अच्छा छोटा infiltrate है, उसकी वजह से उसको pain है, so there's no foreign body. Very easy to remove, because the patient had presented earlier, the epithelial defect, it had not healed. So you just push it, or you can push with one forceps, pull out with the other one. Now the third case was diagnosed as epithelial defect, a non-healing epithelial defect, and the patient came ke symptoms kam nahi ho rahe, had already consulted an ophthalmologist. But I'm pretty sure that that ophthalmologist did not stain the cornea, because when you stain, you're seeing those linear abrasions. The cornea is saying, yelling, please evert the eyelid, there is something there that is continuously scratching on me. So you evert the eyelid. Now this again, if you have patients who are coming from a rural area, you are definitely going to see a lot of these cases of, okay, so now when I everted the eyelid, again, nothing was very obvious. Then there was a small mucus plug sitting there. When I stained and again I everted the eyelid, that mucus plug is still sitting there. Usually if it is a mucus plug, once you evert again, that moves. Here it is still sitting there. So when you see a mucus plug sitting there which is not moving, at least take a bud and remove that plug. Usually when there is a protruding foreign body, that's a natural way of mechanism of the mucus will cover it up so that the pricking sensations will be much less. So only when I remove that and carefully I see there is a caterpillar hair. So these cases are very common, and you see multiple of them, and they get buried deep into the tarsal plate. Sometimes you have to call them second or third day and you see more of them. There have been cases where the caterpillar hair has been found into the cornea, into the anterior chamber, even into the retina, in the posterior segment. Now removing this, if you directly try to remove by forceps, sometimes it gets buried even deeper. So first use a 26G, tease it out a little, and then take the forceps and pull it out. So why was this missed? Because of inadequate examination. Either you did not stain or did not evert the eyelids. Now it is wise to learn from our experience, but it is wiser to learn from the experience of others. So when I did a literature search while I was preparing for this, you see some interesting case reports. So there is something called teddy bear granuloma, where the teddy bear hair in the kids that got accumulated and formed in granuloma, which resulted in a corneal infiltrate and corneal melting like this. This was very surprising. I mean, even I used to put bindi to my daughter. After seeing this, I've stopped it because bindi got lodged into the fornix in a kid, and that has resulted in this corneal lesion. This is very common, insect wing. So you don't want to miss this, and a patient comes to you with an infiltrate and then you evert and then you find that there was a tiny wing. Now this is something we definitely don't want to do, is miss a metallic foreign body under the eyelid and get it on an X-ray. You see a metallic foreign body on an X-ray, which was just, all that you have to do is just evert the eyelid. Now refractile foreign bodies or glass foreign bodies are very, very easy to miss. Like in this case. So here I would like to describe a shadow sign. So if there is anything on the cornea, an epithelial defect or a dendrite or a foreign body, it will, when you throw a light on it, it will cast a shadow on the iris. So that shadow, when you move your light, that shadow also moves. So you know that, okay, there is something, you defocus and look at the cornea, what have you missed. Always look for the meibomian gland openings. When you see there is some staining on the cornea, you see the patient is complaining consistently of foreign body, look at the glands. I as a postgraduate never, I mean this was new to me as well when I did a literature search. So in the meibomian glands opening or in a punctum, you will see a cilia or a foreign body that is sitting there, and it is constantly irritating the surface.
Asmita, can you conclude?
So summarizing, direct broad illumination, after which do an indirect or a retro illumination, always stain, look for the shadow sign, and lastly, redness never lies. So when there is a localized redness in an area, so search in that area, you will find something. Thank you for your kind attention.
Thank you, Asmita. This is wonderfully covered.